So that actually is a great
Ajay.
segue, because I just want to very briefly touch on consolidation and maintenance. You said RVD consolidation. Is everybody using consolidation if their patient's not in complete remission after transplant, or are you going straight to lenalidomide maintenance? What do you do?
So the only people we formally do consolidation on are the high risk.
And by consolidation, we mean more RVD, basically.
On a 3-week cycle, as opposed to our maintenance schedule, which is a 4-week cycle, or the 414s, who we give single agent bortezomib to.
414 being a high-risk subgroup of
we give them
myeloma.
2 cycles of RVD consolidation before we go to bortezomib maintenance.
Anybody do anything differently? It seems like, I must say I've not formally adopted routine consolidation. I mean, sort of patient by patient. You know, some of them I think for sure they should have some. Some I'm like, oh, you can go straight to maintenance. But I don't know if I'm right or not. So.
Yeah, I agree. I think that it's more of a risk-adapted approach. And so those patients, maybe not who are still in a partial remission, you may want to give a little bit more maintenance or more consolidation therapy. But I think in general, it's more of a risk-adapted approach.
But those are, those are rare when you think about it.
They are.
Most of the data for consolidation comes from European trials where they used a doublet up front. They didn't use a triplet. And very few of our patients are not in VGPR or better after a transplant. I agree. At least in our experience.
So it's a really minority of patients, I agree, because that data doesn't really apply to the US.
That brings me to the question of minimal residual disease, interestingly enough. And so when you talk about CR after transplant, are you talking about looks okay under the microscope, or are you talking about by 1 million genomic sequences you don't find any? What's your point?
Well, I think as our treatments are getting better, we can't be using the old methods of evaluation. So we can't be using, for example, quantitative immunoglobulins. We've moved past to IFE. So if you're now going to add very efficacious and expensive new agents, there needs to be proof of improved outcomes. And so we need to improve our depth of remission assessment. And I think the problem is it standardized in a way that a community oncologist could know what to do with the results? And I don't think we're there yet. And as somebody brought up the other day at a meeting, you know what a hemoglobin of 8 means anywhere you go in the world. When you get MRD negative, particularly by flow, how many events you count, how long it took to marrow to get to the processing facility, how many channels were tested. It's really
So do you think
hodgepodge.
a community oncologist or somebody who's not in a major academic center, should they be sending bone marrows for flow cytometry or molecular testing, or not yet, to be practical about it?
I don't think we know what to do with it yet, to be honest with you. I mean, it's an interesting piece of information. Most patients, or many patients, are asking for it, but I don't feel like we have the data to act on it yet.
Right. I agree with Sagar. I think MRD is an incredibly important thing for the future, but right now I'm very careful. Again, dependent critically on what's assessed too. The absence of appropriate radiological screening is really relevant, obviously. I go back to one point though, Keith, about this issue of consolidation and maintenance.
Yeah.
I think an adaptive approach makes sense. I will say though, in our own center, we're kind of very guided by the data that supports it, and also protocol. So we do offer consolidation. What tends to stop us is actually toxicology, in other words, side effect profiles that may be an issue that make consolidation worse. We're very impressed because we're lucky enough to sort of get looks at data from our French partners, and suffice to say that with the caveats that these tools are obviously early, but certainly from the caveat of complete response, it does seem that consistently consolidation is making a difference. And that's one of the messages we'll hear at this meeting from Michelle et al., is that the consolidation piece does make a difference, and certainly from the point of view of MRD testing with the caveats.
Just because I'm curious, how long after transplant on the trial, for example, do you wait till patients don't feel particularly good for the first 60 days or so? When do you start them back on treatment?
Great question. The consolidation starts beyond day 60, and you've got a window out till day 120. And obviously, as Ajay and Sagar knows, and so does Jatin, because we're all part of the trial, you've got latitude. The protocol allows you to.
Left out.
We offered it. You didn't want it.
But Paul, I guess the question I would have is, we know that responses continue to deepen after transplant.
Yes.
Even between 3 and 6 months post-auto.
Yep.
So what you may be claiming credit for consolidation for may be the natural clearance of the disease.
True. I think having said that, from some of the randomized studies from Europe, the suggestion is that the consolidation matters.
And also to that point is the duration of LEN maintenance as well, right? So if you're going to have a late response from transplant and you're using LEN to progression as opposed to stopping at 1 year, what is the role of consolidation in that setting?
So I'm going to take this opportunity to just kind of wrap up for where we've been the last 10, 15 minutes. So I hear VRD for most, KRD for some selected patients. Time limited, but we want a deep response, but don't go on forever before you refer them for transplant. Most patients should go for transplant if they can make it. The consensus seems to be building that everybody needs some form of maintenance. Consolidation is a new investigational tool, but appears to be successful in early going, and that the consensus of the group is really lenalidomide maintenance at least until progression. And then I think, although we didn't talk about it, most of us would concur that in a higher risk patient we would maintain a proteasome inhibitor as well. Is that?
I would agree, but again, built from Sagar's work and others. And my only other point would be that the importance of the randomized trial. For patients who are interested in participating in a protocol, we'd really welcome the referrals. We have almost 60 centers across the country. We still have 120 patients to enroll, because I think it's terribly important that we have a US-based trial that guides US practice, because whilst I have the highest degree of respect for our partners overseas, practice patterns are different, and we must have results that are applied to the US population, in particular this issue of maintenance until progression.